It's a very good topic and interesting as well.
Sure.
Okay. Please carry on.
Yes.
And from the participants, if anybody wants to introduce yourself with Professor Rajshekhar, please. You are free to talk to him, please. Anybody of us.
Sir,
Probably they'll have something to ask after my talk.
yes, sir. Basically, this group is called CNW, Continuing
what is that?
Neurosurgical Webinars. This was initially named as Continuing Neurosurgical Workshop just before this Corona era. Just after Corona, this has been changed to Continuing Neurosurgical Webinars.
Webinars.
So we are studying in the Zoom from very beginning of the Corona, just last 6 months.
Yes.
And we are trying to study, discuss in Zoom group almost every day in a week. And we are continuing it for last 6 months.
Very good.
The last 2 weeks, we were discussing about vestibular schwannoma. Different topics regarding vestibular schwannoma. Today is our the last day of this 2 weeks of vestibular schwannoma. So you are basically invited to the finish or to end this concluding remarks actually for the vestibular schwannoma.
Yes. So let's hope that your previous discussions have raised some issues and some questions. I'll be happy to answer whatever I can.
Yes.
So I'm really looking forward to interacting with all of you. So this is a very informal group, I understand?
Definitely.
Yes.
Yeah. So you have just invited anybody, any neurosurgeon in Bangladesh to join you.
Sure.
Yes, sir. Yes.
So this is not affiliated to your society, the Bangladesh Neurosurgical Society. Is this affiliated to that, or is just an independent effort?
Basically, we are very much connected to them. They have their consent, whatever we are doing.
Okay. Good.
And main bulk of this group is from Dhaka Medical College. I'm associate professor in Dhaka Medical College. So we're closely working with our society as well. Though this is not the program of our society.
Yes.
We have many young, energetic doctors, senior residents.
Yes.
So we are very much keen to learn and develop this subject.
Yes, I think these kind of interactions are very useful for everybody. And I think technology has made it convenient for us to do it.
Yes, sir.
And not expensive also. So that's very good. And I think that is one thing the pandemic has, the only good side I probably think. That it's allowed us to do this, because otherwise we wouldn't have gotten down to doing this. With the regular conferences, nobody would sit in front of a TV screen or a laptop and do this. You know, we all wanted to attend conferences, and we thought that's the only way to do things. And we have learned, no, this is probably a better way, if you ask me, more convenient for all of us.
Now we are focusing, how can we start our hands-on supervision through webinar? Is that possible, sir?
To a limited extent, of course. It's there are limitations to this technology, and even clinical teaching, we are finding it is not very easy.
Yeah.
For example, you know, I'm regularly participating in our resident teaching, which is also happening through through Teams, Microsoft Teams. And we are not physically interacting with patients or anything. So it's difficult to demonstrate certain signs, for example, to bring out some signs and things like that. So we must recognize, yes, there is going to be some limitation. But nevertheless, hands-on is going to be difficult. It's you will need somebody, some proctor or somebody on site next to the residents or the junior faculty who will guide them through the hands-on, whether it's a cadaver dissection or a clinical examination or whatever. So
let's see. Dr. Ishtiaq Ahmed has just joined us. He is consultant neurologist from one of the largest corporate hospitals in Bangladesh. Dr. Ishtiaq Ahmed.
Thank you. Nice being on.
Hello. Nice.
I'm a neurologist. I face this problem less often.
Yes. Nice of you to join us.
It's good to know what's going on currently. That's why I'm here.
That's true. That's true. Our specialties are so closely linked.
Yep.
Right.
So many of us is still joining with us.
Sure. We'll wait. I'm in no hurry.
Yes, sir.
So how was the last 2 weeks? What did you do? Did you have a case discussion, or did you put up a case and everybody discussed on how they would approach it, or what kind of a discussions did you have on vestibular schwannomas?
Can anybody of us summarize to him? Anybody? Or someone will do it.
Yeah,
Shuma.
Sir, so basically we have divided the vestibular schwannoma as a whole from the anatomy and pathophysiology, physiology of hearing and everything till the surgical approaches and complications. On every aspect of vestibular schwannoma, basically just last 2 weeks. We have tried to discuss all aspects actually, not case based, but every aspect of theoretical perspective of vestibular schwannoma, and also we have tried to include all aspects of vestibular schwannoma in the last 2 weeks.
Okay.
Techniques also.
Oh, that's a very comprehensive look at vestibular schwannomas, in other words.
Yes.
I think next week now we'll be looking for AVM week. Rather AVM,
Yes.
We will rotate 15 days on AVM.
That's good. So you're covering almost most of neurosurgery.
Yeah.
Yes,
The common conditions, at least.
Yeah.
Yes.
And since it is closed group, I think it is
Yes.
helping us a lot.
Yes. So are you all doing elective cases now or only emergencies?
Initial for 2 or 3 months, we are very much scared. We did few emergency cases only, but for the last 1.5 months, we are doing emergency and some elective cases as well, because we can't make the patients waiting for 3, 4, 5 months, something like this. So we started.
That's true. That's true.
আমরা শোন আস্তে আস্তে শুরু করব কিনা?
হ্যাঁ,
জিজ্ঞেস করো স্যারকে।
স্যার
42 attendees already.
42. I think many of us is still waiting to join with us. Can we wait until 8:05 or?
No problem. Please go ahead. No, we'll wait for some more time.
Yes, 5%.
নিয়ারে ইন্ট্রোডিউস করা দাও, আমাদের যে পোস্টার বানাইছে জাস্ট ইন্ট্রোডিউস করা দাও, ইনফর্মাল যে
নেমতি
তুমি পরিচিত হও।
Yes sir.
নিয়ামতি পরিচিত হও।
Yeah, Nemati, you can share and you can introduce yourself. Nemati, can you hear me?
So did you see our poster, e-poster? Did you like that?
I did. Thank you. Yes, I did see that.
This
It's
poster
nice.
is created by one of our young neurosurgeon. Basically,
Oh, okay.
she's a lady surgeon. She's
Okay.
gonna introduce herself.
Okay.
Please, Nyamati.
Hello, sir. Good evening.
Hello.
Hello, sir. Good evening.
Good evening. Good evening. Nice to
Sir,
meet
how
you.
are you?
I'm fine. Thank you. How are you doing?
Yes, sir. Fine.
Yes. Very nice poster. So I was wondering
Okay,
who.
sir.
I thought you took it down from the net so that the radios. I guess that was that to represent radio surgery on top. The painting or whatever was on top. Was that? What was that supposed to represent? Do we have that poster somewhere so that everyone can see it?
Yeah. Display the diya dao, Nyamati. Shown dao.
Nyamati, can you share? Sir. You can share.
Yeah.
Yes.
It's good.
So can you please explain to us what the various graphics mean? Is that to represent radiation? That's what I thought.
Sir, this is actually.
Yes, tell me.
Sir, actually, I can hear properly. Can you please repeat?
So, no, I asked you the graphics on the top of the e-poster.
Yes, sir.
I presume that is representing radiosurgery.
Yes,
am
sir.
I right? Am I right?
Yes, sir.
Okay.
Yes, sir.
No, I just wondered whether that's what it was supposed to represent.
Yes, sir.
Okay.
Gamma knife is giving to the one of the tumor in the brain. That is the radiosurgery.
Okay. So that is supposed to represent gamma knife. Okay, very nice. Yes.
And a small logo on the left is our.
That's your logo, and it says academia. Is that right?
Yes.
Yeah.
CNW
Academia.
CNW Academia. Okay. Okay. Quite attractive, nice, attractive poster, and gives all the information needed.
Yeah.
Thank you, sir.
Very nice. Nicely done, Saida. Nice.
Thank you,
so,
sir.
Right now, it is about 50 participants right now. Can we start, sir, right now?
Yeah. Sure. So you want me to go ahead and share my screen?
Yes, sir.
Yeah, please. You want to give it a try once?
Yeah. Before that, sir, I want to introduce you in a very brief way.
Okay.
Can everybody mute yourselves? Neurosurgery, a legacy of excellence. This paper was written by Professor Vedantam Rajshekhar in Journal of Neurology India in the year 2015. He rightly mentioned the true legacy of a neurosurgeon is excellence, like Harvey Cushing.
Sabai mute kore dao, please. Sabai mute kore dao.
Like Harvey Cushing. He who is with us today, example of excellence, actually. We can follow him, his legacy. He led Indian neurosurgical community from front and was president of Neurological Society of India, was president Indian Society of Neuro-Oncology, and was president Indian Society of Stereotactic and Functional Neurosurgery. And right now he is working as a professor in the Department of Neurological Sciences in the CMC Vellore. We know very well CMC Vellore. Most of our patients very much like CMC Vellore, actually, to go there to have the service from there, and how they have established their service, not only neurosurgery, in each and every branches in medical science. They have created this excellence. And it is our great honor to have him today to conclude this Vestibular Schwannoma week. Of this promising neurosurgical study group CNW here in Bangladesh. Today's session is going to be moderated by our mentor Shafiqul Islam sir. He is a really pivot to our all activities and who always inspire us and pushes us to cross the boundary here in Bangladesh, and always try to establish the excellence of neurosurgery here. Please, Shafiqul Islam sir.
Good evening, sir, and welcome to this group. We're very much pleased and glad to have you in this group, and thank you very much for your time. And today, in the next 30 minutes or so, we will learn about vestibular schwannoma, about radio aspects of radiosurgery in vestibular schwannoma. So, along with our group, we have some faculties from Bangladesh as well. I already introduced with you Professor Jilur Rahman, Dr. Ishtiaq Ahmed. Now I see Professor Diman Chowdhury. He's professor of skull-based surgery in Bangladesh Sheikh Mujib Medical University, and we have a few more faculties. So please, Professor Rajshekhar, please start your session. We are eagerly waiting for the talk. Please.
Can all of you see my slides?
Yes.
Okay. So I would begin by thanking your group and Sumon in particular and Dr. Islam for the opportunity to share our experience with radiosurgery for vestibular schwannomas here at CMC Vellore. And I must also congratulate you for coming together as a group and pursue academic interests because unfortunately we have lost out on the opportunity to learn from our patients, which is obviously the best kind of learning for us clinicians and doctors. But for every cloud there is a silver lining, and the silver lining is that it has given us time to learn from each other and the opportunity. So thank you once again for making me a part of this learning exercise. What I plan to do is to really focus on case selection for radiosurgery for vestibular schwannomas. Not all of us will have the facility to provide radiosurgery for patients, but we all have an important role to play as a neurosurgeon to guide our patients, because every patient wants something which is non-invasive. They have been misled by several other either doctors or neurosurgeons themselves because they're not aware of what cases are suited for radiosurgery and what cases are not suitable for radiosurgery. So my main intention is to sort of share with you the case selection for radiosurgery. So the ideal treatment for vestibular schwannoma, which all of you are aware is a benign tumor, is that it should provide cure for it. Because it's benign, we should have the opportunity to cure this, the patient of this malady. Ideally, it should be a one-time treatment. We all face this problem of economic, deprivation for our patients. If patients are not rich, they all want, one-time treatment because they have probably sold their land to fund this treatment and they can't afford to have treatment again and again. So it should be a one-time treatment. Obviously, you want to preserve function. As a neurosurgeon, you don't want to damage the patient further from the already existing deficits. In other words, it should have the least amount of morbidity. And again, like I come back to expense, the cost. And a very important aspect that as neurosurgeons, we may not be really focusing on is what is called as quality of life. It's a more comprehensive thing than just, assessing facial function. For example, most of us are sort of focused on facial function because that's the thing that is evident to us and to the patient. But there are many other things that go into making quality of life. I'll talk about that a little bit later. But unfortunately, we also are aware that there is no single treatment modality that fulfills all these criteria for an ideal treatment. So we have three modalities of treatment for a vestibular schwannoma. One, do nothing, but of course follow up the patient. Two, microsurgery, and finally stereotactic radiosurgery. Now, I'm sure that most of you see tumors of this size. And for a tumor of this size, we don't have any option but microsurgery. So there is no question of either observation or radiosurgery. We have to do microsurgery. And if we can do a total excision, great. But the problem is that with a total excision, we may cause facial nerve dysfunction. Hearing is most often gone in these patients, and therefore that's not an issue. But facial nerve function is most often well preserved in this slow-growing tumor. And once we operate on this patient, these patients, they may end up with a total facial palsy. So of course, now more and more surgeons have resorted to subtotal excision to preserve facial nerve function. So it's very clear for these tumors, microsurgery, either with total excision or subtotal excision. So we looked at our experience with giant vestibular schwannomas in 179 patients. Basically, the question we asked ourselves was, is this a single entity, that is anything more than 4 centimeters behaves the same, or is a tumor which is between 4 and 5 centimeters different? Does it behave differently? And are the outcomes different from a tumor which is more than 5 centimeters? See, when you talk about a tumor which is 4 centimeters and a tumor which is 5 centimeters, the difference is not just 1 centimeter. When you look at volumes, which most people who practice radiosurgery look at volumes rather than just the largest diameter, you realize that actually there is a doubling of the volume. For example, a 4 centimeter tumor is almost 30 cc, 35 cc, and a 5 centimeter tumor becomes 60 cc. So there's a big difference. And we all know that when we operate on a tumor, a 4 centimeter tumor takes X amount of time, and a 5 centimeter tumor may take several hours more. And that's the difference between these two tumors of these two sizes. So these are the outcomes. I don't know whether you can read very well, but read the font. It's small, but I'll just sort of summarize it. So we looked at post-operative ventilation, and we found, interestingly, that 8.6% of patients with less than 5 centimeters needed post-op ventilation, whereas 5.4% with more than 5 centimeters. Similarly, tracheostomy rates were slightly even higher in the smaller tumor group, 4.8 versus 3.6. Post-operative hematoma, interestingly, was 5.6 in the 4 centimeter group, 4 to 5 centimeter, whereas it was 1.8 in the more than 5 centimeter. The only big difference was the CSF rhinorrhea or the CSF leak rate through the nose. It was 10.9 in the larger tumor group and 2.4 in the smaller. The mortality rate was not very much different, 1.6 versus 3.6. So when we did the statistics, there was very little difference except the CSF rhinorrhea. So we concluded that there is no difference in the extent of resection, facial nerve preservation, and postoperative complications except rhinorrhea or mortality, and therefore further subdividing these tumors, that is between 4 to 5 and more than 5 for a giant vestibular schwannoma doesn't make any sense. So a giant vestibular schwannoma is probably just a giant vestibular schwannoma, irrespective of its size beyond 4 centimeters. Then we also, this is an earlier paper, in fact, actually a year before that giant vestibular schwannoma paper, we looked at quality of life. This is something that I mentioned earlier. So what we did differently from other quality of life studies in vestibular schwannomas is that we did a prospective study. That means we assessed the quality of life before they went for surgery and after, at 1 year after surgery and 2 years in some patients. We also assessed what is called as the Glasgow Benefit Inventory. And as you can see, most of our patients had giant tumors, 58 out of 100. And these are our results. The interesting thing to note is most patients before surgery have decreased scores in all domains. That is when compared to the normal population of the same age group. But in the follow-up at 1 year, they showed improvement in all domains. And if you looked at the Glasgow benefit inventory, 87% of patients reported improvement, but 12% reported that they had worsened after our surgery. When we looked at the quality of life, more than 60% of patients reported improvement in their quality of life. And that's shown in this, this table where the p-values are shown and all the domains. The domains are shown on the left. There are 8 domains: physical functioning, physical role, and so on. And important to note that even the mental health is affected, the emotional role, the social functioning, vitality, all these are affected by a large vestibular schwannoma. And what you see on the right as MCID is minimally clinical important difference, because just saying that the score improved by 2 points or 3 points, even though statistically significant, doesn't mean anything. The patient has to improve by this much to have a clinically important difference. So the quality of life does improve after a surgery. So, because the question sometimes asked is, are we making these patients worse than what they were? Most often not, but yes, in some patients, the quality of life worsened after surgery. So let me come to the core of today's talk, the small vestibular schwannomas. These are the tumors which are suitable for radiosurgery. So we have 3 categories of small tumors. One are the intracanalicular tumors, in whom you can do observation, radiosurgery, or microsurgery. Then a group between less than 2 centimeters, and then finally 2 to 3 centimeters. So less than 2, again, you have the 3 modalities. But when it comes to more than 2, I think observation is not a modality that you can pursue any further. You need to do something for these patients, either radiosurgery or microsurgery. Now, how do we decide what to do for these patients? So fortunately for us, there are some quality of life studies in small vestibular schwannomas. These are not randomized controlled trials. These are prospective studies. So this is the second best. So this study looked at 80 patients with less than 3 centimeter type vestibular schwannomas. 36 underwent microsurgery, 46 radiosurgery. And they looked at control rate, hearing and facial nerve functioning, some health status questionnaire, and so on. And they concluded that radiosurgery patients were better off at a mean follow-up of 42 months in all these various assessments. And so there is level 2 evidence that radiosurgery is better than microsurgery in a tumor which is less than 3 centimeters. Another study, which was again retrospective, larger group, where they looked at again microsurgery versus radiosurgery with a longer duration of follow-up, almost 6 years. They also used the Glasgow benefit inventory and SF36. The facial nerve functioning was good even after microsurgery, 80%. But the hearing was better after radiosurgery, and the quality of life, interestingly, worsened even after radiosurgery. But it was worse after microsurgery. Again, these authors concluded that radiosurgery is better than microsurgery. So it appears there are several other studies which I haven't referred to, but all of them have given similar kind of data. It appears now that the initial therapy for a small tumor should be radiosurgery. So radiosurgery at present is the treatment of choice for a small tumor less than 2.5 centimeters. But if the tumor is larger than that, I would not recommend radiosurgery, but would recommend microsurgery. It can also be used as an adjuvant therapy for tumors which we leave behind as neurosurgeons. And at present, the maximum dose that we use to treat with radiosurgery is 12 Gray. That is called the covering dose in radiosurgical terms. So I'll come to the case selection. How do you decide, even for a small tumor, what do you, for a vestibular schwannoma, how do you decide? Size of the tumor I've already referred to, but you also need to know the tumor biology. Is this tumor, how is it behaving? Is this tumor growing rapidly? Is it growing slowly? It is not growing at all. Because remember, not all vestibular schwannomas grow. The natural history is very variable. You need to know the age of the patient. What is suitable for a young patient may not be suitable for an older patient. The patient's symptoms, of course, play a role. The hearing status, presence of comorbidities, of course. If the patient has got a lot of comorbidities, even a young patient may not be suitable for microsurgery, may not be suitable for anesthesia. A patient with bilateral vestibular schwannomas of different sizes may be suitable for radiosurgery or microsurgery. And most important, after discussing with the patient and the relatives, it's the patient's choice that ultimately matters. The patient needs to decide what type of treatment they can have, provided both or all three options are available. Remember, for a giant vestibular schwannoma, if the patient says, I want radiosurgery, there's no way you can offer radiosurgery for that patient. You have to take it out. So again, looking at SRS less than 25 millimeters, I usually like to see tumor growth for very small intracanalicular tumors. If the tumor is 25 or 20, then no problems. But if it is 5, 6 millimeters intracanalicular, I may not give radiosurgery as the first, at the first meeting with the patient. I may say, let us wait and see. Usually, an elderly patient, I will offer radiosurgery, and if the hearing is lost, and if there are comorbidities. So, if the patient has all of these features, then radiosurgery is the ideal treatment. What about a patient with NF2? When the hearing is present in only, or is the only hearing here, if there is growth documented, if there is no growth documented, then I would wait and watch if it is the only hearing here. But if the tumor is growing, then of course, radiosurgery is preferred over microsurgery. And for a patient with neurofibromatosis type 2, I may give stereotactic radiotherapy, not stereotactic radiosurgery. I'll talk about that a little later in my presentation. So what happens to hearing after radiosurgery for small tumors? So that has been studied in these 44 patients where 12 gray was given and a follow-up was minimum of 5 years. They did not look at the cochlear dose, but now we know that we need to limit the dose to the cochlea to less than 4 gray. And 50% of patients had hearing at 5 years after radiosurgery. Remember, these patients all had serviceable hearing. That means they were using that ear for hearing, when using a telephone. And after 5 years, 50% had lost that hearing. So even with radiosurgery, you must caution the patient that the hearing will not remain normal for several years. Some patients are lucky, they may have it for several years, but in 50%, it will decay after 5 years. So these are the overall results that I have summarized from literature. That in radiosurgery, we do not talk about cure. Remember, in my first slide, I talked about cure as the goal of treatment of vestibular schwannomas. But with radiosurgery, we only talk of tumor control. And that's 95 to 98% at 10 years. And more than 70% of patients will have reduction in tumor volume. What about cystic tumors? There is a lot of misconception that cystic tumors are not suitable for radiosurgery. That's not true. 90% of cystic tumors do decrease in size or become controlled with no further growth. Hearing preservation, I've already talked about. Facial nerve function is between 95 to 99%. Trigeminal function, although there is 80% reported in literature, at present it's over 95%. And finally, remember, there is no difference shown in outcomes between gamma knife and LINAC-based radiosurgery. Okay, so a lot of people who use only the gamma knife will tell you that it's better than LINAC-based. That's not true. There has been no literature to suggest that, although there are no RCTs. So here are some examples of cases we have managed. This is what the tumor does after radiosurgery. So a uniformly enhancing tumor, ideal case, about 2 centimeters sized. This is what happens to it. There is central necrosis. The tumor growth is arrested. It doesn't grow further. It remains the same. Okay, but you start seeing central necrosis. And this tumor may shrink with further follow-up. This is at 1 year. But this is something that is seen in about 20% of patients and can alarm the patient and more often alarm the referring physician or even the radiologist. The radiologist will tell the patient, your tumor is growing now after 1 year. So when a follow-up MRI is done after 1 year, you can see growth in the tumor, but remember the central necrosis is an important indicator that radiosurgery is working. This tumor has grown from this size, it has grown. Yes, agreed, it has grown, but there is no need to get alarmed. Patient, you'll need to reassure the patient, don't worry, as long as the patient is asymptomatic. If the patient is symptomatic, you can treat with steroids, but most often the patients don't require any therapy. And you see what has happened to it after one more year, 2 years, and 4 and 5 years later. You see, ultimately the tumor has shrunk compared to the initial size. This is called pseudo progression, and it's a very common phenomenon following radiosurgery for vestibular schwannoma. If you're going to refer a patient, you should be aware of that, so that you can reassure the patient. Patient can say that, you know, the radiologist said, don't go in and operate on these patients. You don't need to. You lose all the benefit that you gave to the patient by sending the patient for radiosurgery. Now, this is what most neurosurgeons are slowly practicing, or more and more neurosurgeons rather are practicing, hybrid surgery for large and giant vestibular schwannomas. Patient says, is there any way, doc, that you can preserve the facial nerve? You say the only way I can be more or less sure, it should never guarantee, I tell you, because even with a planned subtotal excision, you may damage the facial nerve, but there are more chances that you'll preserve the facial nerve if you do what is called as a planned subtotal excision, leaving tumor on and around the facial nerve. You must do a postoperative imaging within the first week to assess the size of the residue, because I can tell you that when we start doing this, you tend to leave large amounts of tumor which may not be suitable for radiosurgery. So you may have to go in again and take out some more tumor. This has happened to me, it has happened to my colleagues, and I'm seeing this when it's a patient that referred to us for always how much tumor you should leave behind so that the residue is suitable for radiosurgery. And when do you plan the radiosurgery? Never do it immediately after your microsurgery. That means within a week or 2 weeks or 1 month even. Wait for 6 months, nothing to lose. What happens is the residue will fold around itself and make a nice ball, which is a good target for radiosurgery. So you plan radiosurgery if significant. So what is significant? This is debatable. I would say about anything more than a centimeter is significant, but you can argue with that. You can say, why 1 centimeter, why not 7 millimeter, why not 8, or why not 1.2? I don't know. There are no answers for this, no evidence in literature. But if there is very tiny residue, I'll show you what I mean by very tiny. You can follow up, you can give the option of follow-up to the patient, but whether you have left a significant or insignificant residue, if you have left a residue in a vestibular schwannoma, you have to tell the patient that they have to come for periodic follow-up. Otherwise, you will have a patient coming back to you after 6, 7, 8 years with a giant vestibular schwannoma coming back again. So this is very crucial. Patient compliance with periodic follow-up is essential, and this I know is a problem both in India and in Bangladesh. So we must sit down with the patient before you plan this hybrid surgery, that are they willing to come for regular follow-up? Only if they're willing to come for regular follow-up should you go for this surgery. And so we looked at this because we were concerned. So we looked at our series of 294 consecutive patients in whom we did subtotal or near total in 55. After discussing all this, okay, in the others, we did a total excision, 81.3. And we followed them up, 52 for some degree of follow-up through telephone, 94.5%. But radiological follow-up, 85.5. This is at a mean follow-up of more than 3 years, 6 to 126 months. So this is a flow chart showing you what happened to our patients. So 239 underwent gross total resection. Even in this group, you need follow-up. Believe me, what we think is gross total resection, sometimes there is a tiny residue and you only see it if you follow them up carefully. So no follow-up in 30%. follow-up in approximately 70%. So what happened to those patients who were willing to come for follow-up? Remember, near total resection 65%. In 31%, we did radiosurgery, therapy is completed. What about in the other 25 patients, 69% of near total? Completed therapy through regular follow-up. They still are undergoing therapy because they need continued follow-up. But this is what is worrisome. Incomplete. They came for one follow-up, didn't come for further follow-ups. What about the subtotal resection? 15 went for more in the subtotal group because a larger residue went for radiosurgery after 6 months, 79%. But 4, we didn't give radiosurgery for various reasons. Either patients didn't want to come for radiosurgery or didn't come and said, no, we want to have follow-up. 2 are coming for follow-up, so they have completed therapy, but 2 have not come for follow-up, incomplete therapy. So you have these 21 out of the 55 patients who did not complete therapy. Remember, if you had excised them completely, at least therapy would have been complete. So this is one of the big pitfalls of so-called hybrid surgery. You need to keep this in mind when you do this. So these are examples of patients who underwent hybrid surgery, fairly large tumor, left a small residue. Now, is this significant or not? I'm not very sure. Maybe we could follow this up. But if the patient is somebody who may not come for further follow-up, I would rather do radiosurgery because at least I've finished the therapy. So this patient, we did radiosurgery, and after 8 years, regular follow-up, the tumor has not grown. Okay, 2 more patients, pre-op, giant vestibular schwannoma. We left a fairly large residue. This is a subtotal excision. No question of waiting on this patient. You need to do radiosurgery after 6 months, and 3 years later, the small residue is still there. Even bigger tumor, the residue is very small, mostly in the porus. Again, should you wait? I don't know. But this patient opted for radiosurgery. We also advised, and 5 years later, you see the residue has shrunk further. But these patients require continued follow-up. What about this patient? 2005, multicystic tumor. A woman who refused, who wanted facial nerve preservation. So we left a very small tumor. We can't see it in the post-op, 1 week post-op contrast CT scan. 1 year later, we called her back. You see the small residue in the porus. Facial nerve, grade 1, grade 2 at the most. We offered her radiosurgery. She said, no, I don't want radiosurgery. I want to follow up. And she's coming regularly. 2008, still the same size, 2012, 2014. But what worries me is that she hasn't come for follow-up for 5 years. Now, has this grown? I don't know. So this is worrying. Remember, this is 9 years after the treatment, but you need longer follow-up. You need lifelong follow-up in these patients. And of course, a small percentage will fail radiosurgery. Has happened to this patient whom we offered primary radiosurgery. The tumor has grown, as you can see, it has become this big. Both are almost the same magnification, these two, and this tumor has grown. And now this patient has undergone microsurgery. So you need to warn the patient that radiosurgery is not a panacea, not completely foolproof. Some patients will fail therapy. So I want to bring up this entity of SRT, which several of you may not be aware of. It is stereotactic radiotherapy. Most of you are aware of radiosurgery, or all of you are aware of radiosurgery and gamma knife, but SRT is not well known. So now radiation is divided into focal radiation is divided into 3 forms. SRS, of course. Then there is something called hypofractionated SRS, 2 to 5 fractions, which is also called radiosurgery. Mostly it's employed by cyberknife people, and stereotactic radiotherapy. Whereas we give a single dose with radiosurgery, 11 to 13 gray, 12 gray, like I said. Radiotherapy is conventional fractionation, 30 fractions, 1.8 gray for fraction, and you use 54 gray to treat a vestibular schwannoma to 100% isodose. You need to use a linac, you cannot use a gamma knife for this, and we use a mini multi-leaf collimator. So this is what the type of frame we use. It's called the GTC. You can use a mask system. Various types of frames are there. They're called relocatable frames. Not fixed to the skull. So you take it out after the treatment every day and then put it on the next day. And this is the brain lab that we use, and this is the plan. These are called shots. we use multiple shots and treat the tumor. Okay, so what are the advantages? In whom do we give SRT? The advantages are that the neural damage, that's the facial nerve function, and if hearing is preserved, is better with SRT as compared to SRS. And you can also treat larger tumors. Remember, I said I don't give radiosurgery for tumors more than 2.5. There are neurosurgeons who give radiosurgery for up to 3 centimeters, but beyond 3, nobody will give radiosurgery. So this is a fairly large tumor. This lady was around 58 or so. She refused microsurgery. She just was adamant. She said, no, I don't want microsurgery. Do something. So I said, okay, we'll do SRT. Not sure what's going to happen, but she's very fortunate. Look at what has happened. This is a GADO MR, mind you, no enhancement. And this is 8 years down the line. She's coming regularly for follow-up. So this is not to be expected in every patient, but this can happen, you know. This is fortunate. So we gave 30 fraction. That's one of the problems. Patient has to stay in Vellore or wherever they're getting the treatment for 1.5 to 2 months. And look at this patient in whom I had very little to offer. This is a young man from Nepal who came to me in 1998, giant tumor. He was 22 years old. It was a hypervascular vestibular schwannoma. And as you can see, I didn't do a very good job. I took out quite a bit of the cerebellum, and I took out maybe 20% or 10 to 20% of the tumor. Terrible. Luckily, facial nerve was preserved, of course. I never went near the facial nerve, so it was preserved. So what do I do? Too large for even SRT. So I had no option. I said, let me do just conventional radiation because I had nothing else to offer him. And I said, let it shrink and I will take it out again. So we gave radiation and he would come every year and he said, I'm doing well. Dr. Saab, I'm bilkul theek hai. So I don't want any further surgery. And I was following him up. And this is 4 years later, the tumor had started shrinking. And you see what has happened after 16 years, hardly see any tumor. And he still comes to me. Look at the tumor, almost completely disappeared. I know the cerebellum looks terrible. That's me. It's not the radiation. It's the damage I have done. But nevertheless, this patient has done so well, facial nerve preserved, and this is 20 years down the line. Of course, I told him he's a lifelong follow-up and he'll keep coming. So I want to leave you with this algorithm, which I've taken from this article. So small tumors, and they have used the Coos staging, 0 to 20 millimeters, no tumor growth, you can wait and watch. If the tumor is growing, or if there are progressive symptoms, go for radiosurgery. And I would do it up to 25 millimeters. If it is more than 25 millimeters and anything in Coos stage 4 or even stage 3 with more than 25 millimeters, I would do combined approach if the patient is willing to come for periodic follow-up. If not, I will say, I'm sorry, I will try my best, but I will take out the tumor completely. Hopefully, at least you get a cure. 1 or 2 follow-ups and I've shown no residue, you can consider yourself more or less cured. But remember, there is a large study from Mayo Clinic where they have shown 40% recurrence after 20 years in so-called total excision of a vestibular schwannoma. They have demonstrated total excision with post-op CT or MRI, and the tumors have come back in 40%. That's a very humbling data for us as neurosurgeons. So please tell patients that keep coming for follow-ups and have periodic imaging. So I want to leave you with these conclusions. Again, I think radiosurgery is the best treatment option, and anybody having a tumor less than 25, whatever age now, I will suggest radiosurgery without any hesitation, because I'm convinced that if I had such a tumor, I would go for radiosurgery. But remember, you also need to document growth for small tumors, intracanalicular tumors, for example, worsening symptoms, hearing loss before radiosurgery, because observation is the best quality of life. As far as quality of life goes, it's even better than radiosurgery. So hybrid surgery, you do radiosurgery if you have a significant residue. But remember, before you get into hybrid surgery, counsel the patient and remind them that surgery is not the end of therapy. ultimately, I think we need to individualize therapy for each patient. There is no one size fits all for these patients. I think I'm done, and thank you very much for your attention, and I'll be very happy to answer any questions that you may have.
Thank you, sir. Thank you very much. Thank you very much for your beautiful talk. There are many questions already we had.
Sure, I'll be happy to answer. I think we have about 20-25 minutes. We started 5 minutes late, so.
For that, can I ask, request our senior professors to pass their comments? Professor Jillu Rahman, sir. Sir, do you have any comments or query on this? Jillu Rahman, sir.
Thank you, Professor Rajshekhar, for your nice and brilliant presentation. And I think definitely you have covered everything, and but there are many interesting and unseen and unknown things to me to explore, and I am very much benefited with your talk, especially the cystic tumor and small tumor. There are multiple options to observe, and SRS therapy, and then observe. These are the options. It is nice and beautifully you have taught. So I must congratulate you and hope to see you again in a different topic. Nice to see you. Thank you very much. Thank you.
Thank you, sir. Thank you for your nice comment.
Yeah.
May I request Professor Dhiman Chaudhary? He is skull-base surgeon, Professor of skull-base surgery.
Hello,
Thank
Dr.
you.
Chaudhary.
Medical University. For his valuable comment, please.
Yeah.
Thank you, Dr. Shafik. Very good evening to Professor Rajshekhar. I know Professor Rajshekhar for a long time. He's a great surgeon, and top of that, he's a very great teacher. So he's a very good name in all over the India as a good teacher.
Thank you. Thank you.
He all time teach in a very simplest way. I observed. I'm following him for a long time in the exam in all also. It's conducted by Professor Manas. So I have given a very nice talk today. So I have a few small questions. Nowadays, there is talk is coming up for the radiation-related malignant transformation. I have no idea. Can you explain it for?
Sure. Sorry, I should have covered that. I know, Dr. Chaudhary, it's a very important question, and I know patients will ask about that. I should have covered that. Is my mistake. The data on that is very sparse, but it is there. It's not zero, but it's so low. The malignant transformation, it's called malignant triton tumor. Vestibular schwannoma can convert into a malignant tumor, but the chances are a little higher in patients with neurofibromatosis type 2 as compared to those with sporadic vestibular schwannomas. So in a patient with a sporadic vestibular schwannoma, the chance is even more remote. So I would not really alarm the patient by talking about it. I suppose for medical legal purposes, you may have to mention it, but you'll have to tell them that the chances are so low that the benefits of radiosurgery outweigh the the risks of getting malignant transformation. So I don't think it is something that we need to worry about too much. But of course, in the patient in whom it happens, it's a disaster. I have fortunately never seen it, but it has been reported in literature, and they've calculated that the chances are, I don't know the exact figure, but it's so very, very low. It's of the order of 1 in 10,000 or something like that. It's very low.
Sir,
any one other question? Sorry, Dr. Rana.
Please. Yes, sir.
So can you explain it, sir? What is the percentage? You mean it? The left behind tumor that is significant and insignificant residue. What will be the percentage?
I
Sir,
wish
this
I knew the answer to that.
For my understanding.
Yeah. So we looked at literature to see what are the definitions people use for near total and subtotal resection. Some people have used absolute volumes, saying, you know, anything less than 1.5 cc, for example. Volumes are what are looked at. Some people have used percentage of the original tumor. So when you have a 30 cc tumor and you leave a 3 cc residue, that is 10% residue. So, you know, that would be called subtotal resection. Some people have suggested that that is subtotal resection, and you know, so absolute versus relative or a percentage, it's very difficult to compare. So what we have done is anything more than 90% excision is what we would call a near total resection, or 95% if I'm not mistaken. And anything less than 95% resection is called subtotal resection, up to 80%, and anything below that is partial. So again, it depends on the original size of the tumor. So there is no definition for what is significant, what is insignificant, and it is something that it's an eyeballing. I think, like I showed you through examples, what I would consider significant and what I would consider insignificant. Like you saw that just the intracanalular little residue in that lady in whom she did refuse radiosurgery, I would say that is insignificant. That can be followed up. But something which is sticking out of the porus, coming into the CP angle, most of those I would treat with radiosurgery. So I'm sorry, I don't have a definite answer for that, but that's what it is from the literature. So I think each of us has to decide for ourselves. And more importantly, is the patient willing to come for regular follow-up?
Thank you, sir. So I have a fantasy to be a teacher. Thank you, sir.
Thank you.
Thank you, Professor Devan Chaudhary, for your valuable questions and comments. Shubhan, you wanted to ask something?
Yeah, yes. Thank you, sir, for your brilliant queries, so that we have learned a lot from Rajshekhar sir through your questions. I have a complementary question regarding this radiation-induced malignancy. Is there you have got a long follow-up regarding SRS for vestibular schwannoma. What is your experience regarding SRS-induced any tumor like meningioma in the posterior fossa? Is there an experience?
No, I have never seen a radiosurgery-induced tumor till now for not only vestibular schwannomas, but for we have treated a large number of AVMs, for example. But radiation-induced tumors I have seen. Radiation-induced tumors I've seen at least 2 or 3. That is conventional radiation-induced tumors. So radiation does induce tumors. Let us not ignore that fact. But it's exactly the same situation. Do we not give radiation to a patient with a glioma because we are worried that they can be a tumor somewhere down the line? No, because we don't have any other option. So similarly, I think we have to weigh the risks and benefits, and I think we should not really alarm the patient with saying that, you know, this is a big problem. It's not a big problem. It's a small problem, but it is a problem. I agree. So maybe we can disclose this to the patient and tell them that, you know, reassure them. Like when we operate on these patients, the question the patients ask always is, will I be all right? And we say, yeah, there are small risks, but you will be all right. It's exactly the same situation. And we say, yes, we're taking a small risk, but you should be okay. Generally, things go well.
Thank you, sir.
Thank you, sir. There was a question from Shumundar as well. Does radiosurgery works less for a cystic tumor? Or what is your comment on that?
Yeah, so yeah, there was a feeling once upon a time that cystic tumors do not respond well to stereotactic radiosurgery, but that is no longer true. There is enough data from the group from Pittsburgh, Doug Konziolka's group at that time, now Lunsford's group, showing that cystic tumors respond equally well as solid tumors. So I don't think that is a contraindication for stereotactic radiosurgery anymore.
Thank you, sir. We have Dr. Shofil Alam. He is Associate Professor Neurosurgery at the Institute of Neuroscience. Dr. Shofil Alam, you have any query or comments to Professor Rajshekhar?
Hello.
Can you hear? Thank you, Dr. Shafiq Islam, and also very thanks to Dr. Rajshekhar for brilliant and concise presentation. I have a query: which modalities of SRS used, cyber knife, gamma knife, or LINAC? Which one is better in your opinion, especially in case of vestibular schwannoma?
Okay, so like I said, I don't think the modality is important. It's not the modality that is important. Whether I use, by the way, I use LINAC based. I've been using it from 1995. So over nearly 25 years of experience with LINAC based radiosurgery. I don't have any experience with the gamma knife or the cyber knife, but I have talked to a lot of people who have used everything. And everybody says that the modality is not really so important. It's the planning that is important, the structures that you spare, and how you plan your radiation delivery. So ultimately, I think the outcomes are similar, whether you use gamma knife, LINAC, or cyber knife. So it doesn't really matter. For vestibular schwannoma, I think all of them give equally good results or equally bad results, whatever. So I don't think we have very much to choose as far as the modality is concerned.
Thank you very much.
Thank you, sir. There is a tricky question here. If a patient has only one hearing aid,
yes,
in that case, do you change your plan or?
Yeah, this is a very interesting, very important, important question. But usually you have this problem with patients, in patients with neurofibromatosis type 2, NF2, not with sporadic vestibular schwannomas, because most often the other ear is okay, but I can understand, for example, if the other ear has presbyacusis and very poor hearing, and this is the only good ear, or patient has got some other thing like autosclerosis or something, whatever. It can be a problem. So it all depends on the size of the tumor, the age of the patient, and so on. But for the hearing part, if the size is small, I would go for radiosurgery. If the size is large, then you have no option. And if the size is large, it's likely that the patient has already lost hearing. So usually this situation will be present with a small tumor. Let's start with an intracanalicular tumor. Only hearing ear, intracanalicular tumor, don't do anything. Watch, especially in an older patient. Over the age of 60, only hearing ear, intracanalicular tumor, observation. Only hearing ear, whatever the age, tumor is coming out of the porous, go ahead and do radiosurgery, because you may be able to give the patient another 4 or 5 years of serviceable hearing. During that period, tell the patient you are going to lose hearing at some point in time in your life. Start either learning lip reading or sign language. Use that time, that 5 years that you have, to learn the skills so that you can still communicate with others. So that is the advantage of giving radiosurgery. Suppose you operated on this patient, next day the patient will lose the hearing would completely go. Unless it's a very small tumor. If you're lucky, you may be able to spare the hearing, but most of us, we are not so confident that we can spare hearing in a little large tumor, like 2 centimeters, 2.5 centimeters tumor. Intracanalicular, you can, but I would go for radiosurgery. Why would I now do for a small tumor? Why would I do microsurgery? Radiosurgery is very good.
Thank you, sir. There is one more question from Dr. Niyamati. Her question is, how much time needed to reduce the size of the tumor after SRS and recurrence rate after SRS as well?
Yeah. So you need to follow up patients who have had radiosurgery. Like I was saying, I think every patient requires lifelong follow-up, but definitely patients undergoing radiosurgery require close follow-up for the first 5 years at least, because it's been shown that usually the failures occur within the first 2 years. But I have seen failures even a little later, 3-4 years down the line. So I would suggest that patients come for regular follow-up. As far as the shrinkage of the tumor is concerned, you must warn the patient, don't expect shrinkage. The tumor probably will not shrink. Like I said, only about 70% will have some shrinkage. And the tumor disappearing is a very rare event. Some tumor will always be seen after radiosurgery. You must warn the patient that this is going to happen, because if you don't warn the patient, somebody else is going to say, hey, that doctor did not do any treatment. The tumor is still there. That's what they will tell. And this used to happen in the early days of radiosurgery. We used to have patients coming back and saying, somebody has told me you have done nothing, tumor is still there. then we had to keep again sit down and tell them, hey, this is expected. This is what happens with radiosurgery. And as far as recurrence is concerned, or failure, you should talk about failure. Like I said, it's about 5% is what is reported in literature. So I would say 95%, 90 to 95% will be controlled. And also the size of the tumor matters. The larger tumors are more likely to fail than a smaller tumor, fail SRS than a smaller tumor. So I would not push the radiosurgery for something like more than 2.5, although others do it up to 3 centimeters.
Thank you, sir. Dr. Irfan Sawan, you had a question. Can you please ask the question directly to the speaker? Irfan Sawan, please.
Thank you very much, sir. It's actually a great honor for us to have such a big name in Indian neurosurgery amongst us. Thank you, Professor Rajshekhar, sir, for an excellent presentation. My question was, sir, what are the technical points to consider in microsurgery while leaving a tumor for residue for radiosurgery, sir?
Very good question and a very difficult question to answer. Let me be very frank, there is no substitute for experience. Because as you know, intraoperatively to assess the residue for a giant vestibular schwannoma is very difficult. And all the time your concern is, will I damage the facial nerve? So let me share with you what my experience has been. I like to see the brainstem completely, free of tumor. There should be no tumor on the brainstem. You should see the root entry zone of the 7th, 8th very clearly. And of course, you should completely see the 5th nerve bare. You should not have any tumor covering the 5th nerve. You should not have any tumor covering the 9th, 10th. So in other words, your tumor will only be, the residue will be only around the 7th nerve. And on the 7th nerve, you should be able to see the root entry zone. So most of the tumor will be really difficult to remove close to the IAM, just outside the IAM. So I would actually try and remove as much tumor as possible medially, close to the brainstem. And at the porus, if you can drill the porus and get into the porus and remove tumor, you can easily deliver out the lateral part of the tumor. So ultimately, you will have tumor around the porus, which is also, and again, a thin layer. So you can almost sort of rotate the tumor to along the facial to see whether there is that has been published by a former colleague of ours, Dr. Roy Daniel, who's now in Switzerland, is that to use the facial nerve monitor. If most of you are using the facial nerve monitor, what he does is to stimulate the facial nerve through the thickness of the residual tumor. And the formula is that for every 1 milliampere of current, you have 1 millimeter of tumor thickness there. So you can say if you're 5 milliamperes you're using, you got 5 millimeters thick tumor left. If you have 10 milliamperes, if it takes 10 milliampere current to get facial nerve response through the tumor thickness, then you've got 1 centimeter thick tumor left behind. So you can shave off the tumor gradually using a QSA or something and come down to the point where you're getting responses at say 5 milliamperes. So that is another way of reducing the tumor size, thickness of the tumor. But this will not help you to take the tumor off, means to remember to take off the tumor off the 5th nerve. You should see the tentorial edge. You should see the petrosal vein. You should see the 5th nerve. You should see the brainstem. You should see the whole petrous bone, at least the junction of the petrous with the tentorium. You should see the 7th, the 8th, the 9th and 10th cranial nerves below. And so if you see all this, then you can be certain that your tumor residue is small. Otherwise, if you are leaving tumor on the brainstem, then you don't know how much you're left behind. And even with this strategy, you can do either of two things. You can either leave too much tumor or you can damage the facial nerve, both of which you don't want to achieve. So it's a balance. So I hope I have answered, given you some sort of indication of how you can go about achieving the ideal tumor size residue.
I think that's a very elaborative answer, sir. Thank you so much. And once again, an excellent presentation. Thank you, sir.
Thank you, sir. Today we have with us Professor M.M. Ehsanul Haq. Professor Ehsanul Haq, could you tell us something, Professor Ehsanul Haq? He's Professor of Neurosurgery, National Institute of Neuroscience. He left us already? He's here. He's here or he left us? I have a question. My question is, I'm very much attracted on your hybrid way of treating vestibular schwannoma. My question is this the same team? Is it better the same team treating the microsurgery as well as radiosurgery, or microsurgery, surgery people doing microsurgery, and for radiosurgery we are referring the people to the radiotherapist? How do you feel? Is it the same group better or different group better?
Yeah, very, very important point. I am a strong believer that neurosurgeons should be involved in radiosurgery.
Sure.
Remember, the gamma knife is a neurosurgical tool. And neurosurgeons, Lexel, a neurosurgeon, started radiosurgery. So we should not allow this to slip away from our hands. Please remember, never let radiation oncologists totally control radiosurgery. It's a team effort. It's a team effort. I do not deny that. You need the radiation oncologist, no question. By law also you require them. I'm sure Bangladesh also require a radiation oncologist to sign that dose delivery plan and all that. You need a radiation physicist. So it's a team effort, but the leader of the team for radiosurgery at least should be the neurosurgeon. So fortunately for us in Vellore, it's the same team. It's the neurosurgeons who do the surgery also are involved with radiosurgery, of course, with our radiation oncologist colleagues and the radiation physicist. So because we know what we have left behind, the tumor. They shouldn't go to the radiation oncologist, should not ask the radiologist to outline the tumor. The neurosurgeon should draw the residue. Where is the tumor? The neurosurgeon should identify the residue on the MRI and the CT scan. You should not leave it to the radiologist who's never seen this tumor before to draw it out. We are the best judges of where is the residue, not the radiologist, not the radiation oncologist, the leaders of radiosurgery. So it is the same, same team is the people who operated are involved in the planning, definitely.
Thank you, sir.
Thank you.
Dr. Shiplu, you want to add something? Dr. Shiplu, you have something? Any compliment, any questions?
Thank you, sir, for this great opportunity. I just congratulate, sir, for your outstanding lecture on radio surgery on vestibular schwannoma. Congratulations, sir. Thank you.
Thank you. So I just saw one question pop up. Somebody has written in the chat. Somebody can read out some of those questions. But one was an interesting question I just happened to see, where somebody is asked, can we use radiosurgery first and then do microsurgery later? No, that is not an option, because radiosurgery cannot be done for large tumors. And if you're going to do radiosurgery upfront, it should be the primary therapy. That means you have decided that I'm not going to operate on this patient. I'm going to just give them radiosurgery, and that is the definitive treatment. If you're going to do radiosurgery, it's going to be for other tumors, the larger tumor. You've decided this patient is not suitable for radiosurgery because of the size of the tumor, and I'm going to operate, then radiosurgery is only done after the microsurgery, not the other way around. So you cannot reduce the size of the tumor with radiosurgery and then operate. No, it doesn't work like that.
Thank you, sir. And Dr. Aliud Jawan is consultant neurosurgery in Apollo Hospital. Do you have any comment, Dr. Aliud Jawan? Are you there or left us? So there is a question. The question is, do you know really in some of the tumor radio SRS doesn't work? You know the cause?
No, that's a very important, good question. Unfortunately, we don't have any idea. So it is primary radio resistance. We don't know why. Remember, vestibular schwannoma is a very slow growing tumor. So it's actually a tumor that does not respond to conventional radiation, generally doesn't. And that's why we've never been giving conventional radiation to these tumors for so many years. But for some cases, it does work, obviously. Even conventional radiation works. I showed you one case. But radiosurgery is such a high dose being delivered in single fraction, and therefore it destroys slow growing or rapidly multiplying cells and the cells which multiply slowly. They call these alpha fraction, beta fraction, so on and so forth. The radiation oncologists have the tumor biology. So we don't know in whom it's going to be effective and whom it's not going to be. To my knowledge, at least, I haven't seen literature, probably there may be, but I'm not aware of whether anybody has studied and come out with factors which can, prognostic factors, which can predict which vestibular schwannomas will not respond to stereotactic radiosurgery.
Okay, sir, there is a question, why isocenter is usually placed near the brainstem?
Pardon? Isocenter is?
Usually placed near the brainstem. Is that so? I don't know actually.
No, it's not placed near the brainstem. So the isocenter is basically the center of the lesion. That's all. The isocenter, see, so in LINAC-based radiosurgery, we use only one isocenter, typically one isocenter, whereas gamma knife, you place multiple shots. So there's no one isocenter. In gamma knife, you have multiple shots, so multiple isocenters are there, and they are fused together, and then they become a plan. The radiation dose is delivered all around. So the isocenter is not placed near the brainstem. I'm sorry, but it's the center of the lesion, basically. That's it.
One more question there. How can we define SRS failure and protocol for microsurgery in case of SRS failure?
Yeah, so SRS failure is defined by continuing growth of the tumor, not pseudo progression. So if the patient is in the first year, usually you do not, unless it's a rapid growth and the patient is becoming symptomatic, you will consider it as pseudo progression. But beyond a year, if the tumor is still growing and the patient is becoming symptomatic, then you have to do microsurgery. So there are lots of reports of microsurgery after radiosurgery. I have operated on one or two patients who have had radiosurgery elsewhere or even in our own center, and we have had to operate on these patients. So one thing is that the tumor is almost bloodless. It has lost its blood supply totally. And the problem is that the adhesions are there. So the planes are not very good. So what I have done in such cases is that I have not tried to excise this tumor totally. I have taken out as much as possible, as much as is safe, and I have left tumor which is stuck either to the brainstem or the facial nerve or the 9th and 10th. I have left it behind, hoping that the radiation has already done its work and that tumor will not grow. And to my sort of memory, those tumors have not grown. So those are the 2 points. One, it becomes very firm and avascular, and secondly, there is a lot of adhesions with arachnoidal adhesions.
Thank you, sir. I think there is a question you already answered. Is there any time frame for follow-up in case of radiosurgery? I think it is lifelong.
It is for everything, even for total excision. Like I said, now after seeing this Mayo Clinic study, how can we tell a patient that they'll never get it back? So I think we should at least once in 3-4 years get a MRI done for even total excision. So I think it's a lifelong business.
Thank you, sir. I think there is a question from our Indian friend, I would say.
Yes.
Small, less than 2 centimeter, purely cystic tumor. Is this a contraindication for SRS?
Not to my mind. Not to my mind. I would still try radiosurgery. See, one of the things that you can tell the patient is that, a 2 centimeter tumor, cystic tumor, if you're given radiosurgery and if it fails, means most probably it will succeed, 90% chances. If it fails, you always have the option of going in and operating on that patient. So why not take a chance? And of course, the cost is involved is there, but if you go and damage their facial nerve function and it's a small tumor, 2 centimeter, even hearing may be there. So why not give radiosurgery a chance? This is the approach I would take.
Thank you, sir. I think there will be too much questions coming. We already passed more than 1 hour time with you. We learned a lot. That was a beautiful learning curve for us. And radiosurgery is we are very much in the beginning stage of radiosurgery. Many of the centers doesn't have already this kind of facility. I think we'll be having this facility in near future, and definitely we will be seeking your help again and again, so that we can start this field in Bangladesh.
I met Sumon in Delhi in February before the pre-COVID days. I remember right. And yes, so even at that time, he asked me, "Can you help us with any educational activities?" I'm more than willing, and I'm so honored that you wanted me to interact with you and share my experience. So thank you very much. So many of you have, and as a final, one more gesture I sort of want to give to you is that even those who have given questions, if Sumon or somebody can, put them together, I can even answer them through email. If they want, I'll be happy to do that.
Yes, sir. Thank you, sir.
So
I will be able to answer last time.
We are almost close to our session. I deeply thank to some of our Indian friends who joined today's meeting. And can I ask Dr. Ishtiaq Ahmed to say a few words for a few seconds to Professor Rajshekhar. Dr. Ishtiaq Ahmed.
Thank you, Professor. It's a nice talk for me to listen. I'm a neurologist, so I faced fewer of these kind of problem, but it's good to know that what are the cases I will be able to recommend for radiosurgery or for the surgery. If we use the radiosurgery, if there is a significant swelling, and that's what I learned, that steroid could take care of this, or we have to do try surgery for those cases. If I can ask that.
Yeah, sure. Most often, pseudo progression can be treated with steroids. Most often, actually, it doesn't require any therapy. It's asymptomatic. It's just a radiological diagnosis. It's an imaging-based diagnosis. Most often, in a small percentage of these patients, the patients may experience either mild headache, mild dizziness, ataxia, sometimes maybe swelling of the middle cerebral peduncle. So if the patient has those symptoms, then you can give a trial of steroids for about 4 weeks, a tapering course with dexamethasone, and that should take care of it. But in spite of that, the tumor is growing and causing, things like hydrocephalus and things like that, then you may have to go and operate on.
Great learning for me.
Now we are almost at the end of the session. Before giving the mic to Dr. Shumandana for closing remarks, I request my friend, he is Associate Professor of Neurosurgery, National Institute of Neuroscience, Dr. Jainul Islam. Can you say a few words to Professor Rajshekhar? Few words to Professor Rajshekhar.
Thank you, sir. I met in Dhaka a few years back. I heard lots of question and answering session. I learned a lot from your lecture and other answering sessions. Sir, I just one question.
Sure.
Small. That is, do you feel any difficulties after getting the patient SRS during surgery? After getting SRS, do you feel any difficulties during surgery, microsurgery?
Yes, so you can face difficulties, as I mentioned earlier. So the difficulties are related mainly to the adhesions to the surrounding structures, the nerves and the brainstem. So you may face that problem, and in which case I would advise that we should leave that tumor behind. You should not try to peel it off the brainstem or the cranial nerves, because it's possible that the radiation has controlled growth of that part of the tumor. I mean, it's unlikely that that tumor will grow. At least you can take a chance. This is what I have done in the 2 or 3 cases that I have had to operate after radiosurgery.
Yes, sir. Thank you, sir. Actually, I went through lots of paper from your writings, especially on steroid primary research work from you on dexamethasone. So and hydrocephalus also. So whenever I got your paper, I usually used to go through your paper. Thank you, sir. Thank you so much.
Thank you.
Thank you, sir. Over to Shuman.
Yeah, thank you, sir. Basically, sir is the excellence of neurosurgery here in this subcontinent, not only in the subcontinent, but also in the world. We have learned a lot through his papers, his teaching. And basically, if we join any seminar, we can see ultimately microphone goes to him for the final remarks and expert comment, and how he commented on the topics, any topics, is really amazing, and we can understand very clearly from his talk. It's our great pleasure to have him in our concluding day of this vestibular schwannoma weeks. Everybody of us already we know, and I would request sir to say a few words in our concluding day of this vestibular schwannoma.
Especially for young surgeons and residents.
Yes.
So you wanted me to say something?
Yeah.
Yes.
It's kind of motivational talk for them, sir.
Okay. So to all the young neurosurgeons and neurosurgeons in training, I think you have chosen a very difficult but rewarding specialty. See, when I just wanted to mention my teacher, whom I talk about a lot, Professor K.V. Mathai. When I joined neurosurgery, he asked me, "Are you married?" So I said no, and he told me that whoever you're going to marry, please tell her that she will be your second wife. So because neurosurgery is always going to be your first wife. So that is the kind of commitment and we have to have towards our subject. And only then can we deliver the best for our patients. So I think neurosurgery cannot be a hobby. Neurosurgery cannot be a hobby. It is a lifelong commitment, and it's 24/7. I'm not suggesting other specialties. There is a neurologist, Dr. Ahmed is there as a neurologist. I'm not suggesting that is not a lifelong commitment. It is, but it is demanding. Neurosurgery is demanding because the margin for error for us is so small. You know, you may think after striving for 8 hours in the operating room, especially a giant vestibular schwannomas. I know that after every giant vestibular schwannoma, I would not sleep well that night, because I'm waiting for the phone to ring and one of my colleagues telling me, "Sir, this patient has had this problem or that problem." That used to be my biggest nightmare. So I used to just wait for dawn, for the light, the sun to come up, to say, without a phone call, that, the big problems, at least the major problems haven't occurred. So it's that kind of, the stress that we have to go through. And the only other point I want to make is that please study your cases carefully. Whatever you do, keep track of them, keep records, because only through your own experience, see, don't believe me when I say that these are my results, these are my facial nerves sparing, or this is my mortality in my series. I'm talking about me personally, because your experience will be different. So use your own experience to judge other people's experience, because not everything that is printed, not everything that is spoken in a conference is true. Unfortunately, that is the truth actually. So your experience is the best experience. And for that, you cannot say last case, did well, but you forget the case that didn't do well. So you need data. So that comes through only keeping records of your patients. How are they doing? Because you can only learn if you know where you are. If you don't know where you are, if you don't know what your knowledge base is or what your skill base is, how can you improve? You can only improve if you know where you are, and you'll know where you are with your own data. So I just want to leave these two thoughts with you, and I want to wish all of you all the very best. And I'm sure that with these kind of activities, you will only improve your knowledge base and also your skills. Thank you very much, and have a good night.
I request everybody to open their video and put our hands together to give big hands for Prof. Rajshekhar.
Thank you very much. Very kind of you. Okay. Good night.
Thank you. Good night, sir. Thank you.
Good night. And thank you, sir.
Thank you, sir.
Good night, sir.
Thank you, sir. Hope to meet you soon. Thank you, sir. স্যার আমাদের প্রোগ্রামে যারা এসেছেন আমাদের দেশের আমাদের মুরব্বী ফ্যাকাল্টি স্যার সবাইকে স্যার আন্তরিকভাবে ধন্যবাদ। ধীমান স্যার অসংখ্য ধন্যবাদ।
না না শফিক চমৎকার তোমার প্রেজেন্টেশন আর মডারেশন অসাধারণ অসাধারণ থ্যাঙ্কস
ধন্যবাদ সবাইকে ধন্যবাদ
সবাইকে ঈদ মোবারক ঈদের শুভেচ্ছা এবং কোভিড পিরিয়ডে আমরা সবাই ভালো থাকি সবাই সবার জন্য দোয়া করি
অবশ্যই
যারা আমাদের মাঝে এখনো কোভিডে আক্রান্ত হয়ে আছেন তাদের জন্য সুস্থতার জন্য সবাই দোয়া করি আমরা সবাই ভালো থাকি ঘরে থাকি ঈদ মোবারক
রাজীবের জন্য একটু দোয়া করবেন
অবশ্যই অবশ্যই
অবশ্যই
থ্যাংক ইউ স্যার
থ্যাংক ইউ বাই